Hello, everyone, and thank you for joining our afternoon session on our inaugural conference on student mental health research here at the University of Waterloo. I am pleased to moderate the next panel session, which will be focusing on student mental health and the effects of COVID-19. So there will be three presenters as part of this panel. The first will be Chloe Hamza, who is a professor in applied psychology and human development at the University of Toronto. And our next presenter will be Kira Cooper, who is a PhD candidate in the School of Environment, Resources, and Sustainability. And then finally, we will have Sarena Daljeet, who is a master's student in the clinical psychology department here at the University of Waterloo. During the session, I will be moderating the questions that come in. If you use the Q&A function on Microsoft Teams, I will publish your questions and I will read them out loud at the end of the session. So there will be a 15-minute Q&A after all of the presenters are finished. So without further ado, Chloe, you may start presenting.
Can you see my slides okay?
Yes, looks great.
Okay, perfect. Good afternoon, everyone. I'm really pleased to be here. Thanks so much for having me. Today, I'm going to be talking about a longitudinal study that my colleagues and I recently conducted that focused on the psychological impacts of COVID-19 among students with and without pre-existing mental health concerns. So in the next 10 minutes, I'm going to briefly contextualize our work by talking a little bit about the literature on student mental health and the potential impacts of COVID-19. I'll also briefly highlight why we wanted to consider these impacts specifically among students with pre-existing mental health concerns. I'll then talk about our methodology. I'll provide you with a quick snapshot, talk about some key findings, and then we'll talk about some discussions and implications of this work. So prior to the pandemic, we know that student mental health was already at the forefront of public health concerns. So as many as 1 in 5 post-secondary students met the diagnostic criteria for a mental health disorder. Need for access to care on college and university campuses was already increasing. As a result of the pandemic, students are facing new and unprecedented changes. So we've had, campus closures, widespread transition to remote learning, as well in some places stay-at-home orders and disruption in research and internship placements. So as a result of some of these changes, many authors have cautioned that students who were already a developmentally vulnerable population may be at risk for worsening mental health, and that those students with pre-existing mental health concerns may be particularly vulnerable. So for example, uncertainty stemming from COVID-19 could exacerbate symptoms of anxiety among students with pre-existing mental health concerns. That being said, to date, we know that research on the psychological impacts of COVID-19 among students is scarce. There are findings starting to emerge on general population samples, and typically we find that about 1 in 4 are experiencing distress in the context of the pandemic. So things like depressive symptoms, binge drinking, anxiety, PTSD symptoms. A significant limitation of this literature, though, is a lack of pre-COVID-19 assessment. And so it's difficult to actually ascertain whether there's been changes in mental health before and during the pandemic. Additionally, researchers have really yet to explore the differential impacts of COVID-19 on students with and without pre-existing mental health concerns. So in the present study, we sought to provide a much needed examination of the mental health impacts of COVID-19 among post-secondary students, as well as identify those students who may be most vulnerable to the psychological impacts of COVID-19. So to do this, we actually followed up with a group of participants who'd already done a study in our lab before the pandemic, after the pandemic had started. And we really expected to find that students would experience worsening mental health in the context of the pandemic, and that students with pre-existing mental health concerns would be those most at risk. So the present sample consisted of 733 university students at the University of Toronto who filled out an online Qualtrics survey in May 2019, again in May 2020. And on this survey, we included several measures of stress and mental health. To capture stress, for example, we used the inventory of college students' recent life experiences. So this measure includes many sort of subscales of stressors that students commonly experience, things like developmental challenge, time pressures, romantic problems, assorted annoyances, and social mistreatment, which taps into social isolation and disconnection. We also assess several mental health indices, and I've provided a list of some of these indices here for you. Ones that I'll present on today included, depressive symptoms, anxiety, BPD or borderline personality disorder symptoms, and alcohol disorder symptoms. So we used previously established cutoff scores on the mental health indicators to identify students with pre-existing mental health concerns at time 1, so at the assessment point prior to the pandemic. And then we use repeated measures ANOVAs of stress and the mental health indices with pre-existing mental health status as the between subjects factor to look at change in these indices by group. And then significant time by group effects were followed up using paired samples t-tests. So we really wanted to probe where were these changes happening for those students with pre-existing and those without pre-existing mental health concerns, and how might these patterns differ for these two groups. So here I'm really trying to sort of summarize our key findings or our takeaways. We included more obviously in the paper, but in this table you can see that we have means on each study variable at time 1 and time 2 organized by group. So students with pre-existing mental health concerns and students without pre-existing mental health concerns. Interestingly, in short, we found that for many of the groups, for both groups, many of the stressors actually declined from time 1 to time 2. However, interestingly, we did find that there was a significant effect of group membership on social mistreatment, which again taps social isolation, such that those students with pre-existing mental health concerns showed no changes sort of before and during the pandemic, whereas students without pre-existing mental health concerns showed increasing social mistreatment. We also found group effects such that individuals who had pre-existing mental health concerns showed comparable, if not improving mental health during the pandemic, whereas for students without pre-existing mental health concerns, they showed worsening mental health. So again, just to sort of illustrate these findings, as you can see here in the graph, we have time on the x-axis, so time 1 and time 2, and on the y-axis, we have the social mistreatment score, which is essentially tapping, social isolation and disconnection. The green bar is those with pre-existing, the blue bar is those with no pre-existing. And the point we kind of want to highlight here is that we found that students without pre-existing mental health concerns were the ones who showed increasing social isolation. And it was also these students who showed increasing depressive symptoms, anxiety, and BPD symptoms. So we think what's going on is that these students were the ones who experienced new social isolation or increasing social isolation, which is adversely affecting their mental health. So contrary to expectations, we found that students without pre-existing mental health concerns were actually the ones that showed declining mental health in the context of the pandemic. And one reason we think this is because these students also showed increasing social isolation, whereas students with pre-existing mental health concerns showed comparable levels of social isolation both before and during the pandemic. So we think that these findings really underscore that colleges and universities will not only need to continue to support students with pre-existing mental health concerns, but also prioritize the early sort of prevention or mitigation effects of mitigate the effects of COVID-19 on students who are experiencing worsening mental health, potentially stemming from increased social isolation. So although our study has many notable strengths, including its focus on a post-secondary sample and its use of a pre-pandemic assessment point. I did just want to highlight a few limitations because I think they really underscore, the necessity of future research in this area. So first and foremost, data was collected at one university, and so the extent to which these findings are generalizable to other institutions remains to be determined. For example, in other countries, academic institutions have had varying responses to COVID-19, including restrictions placed. So we think there's certainly the need for more research on more diverse samples. I should also add we specifically assessed participants in May 2020. So the psychological impacts of COVID-19 may have been more pronounced at the start of the pandemic, or they may worsen over time, right? So we're in a new academic year, new stressors for students, and so we think ongoing work is necessary. I also just wanted to highlight that there might be other stressors that we weren't addressing that could be relevant to understanding the psychological impacts of COVID-19, such as having a close loved one lost or having COVID-19, for example, which are probably important to study. So hopefully our study serves as a starting point for additional research in this area. So just to wrap up, and I think I'm right on time here, I just wanted to thank my collaborators, Lexi Yoon, Abby Goldstein, Nancy Heath, and the rest of the Care Lab, acknowledge funding from SSHRC, and note that we do have an online first version of this publication available. Thank you so much.
Hello, everyone. My name's Kira. I just trying to get my screen visible. Can anyone confirm if they can see it?
I can see the PowerPoint and all the slides along the side.
How is it looking now? Good to go?
Yes, yeah, perfect.
Perfect. Thank you so much. That was a great presentation and a really nice introduction to the work that I'll be presenting. So my name is Kira. I'm a PhD candidate in the Faculty of Environment in SURS. So my research is looking at mindfulness and its role during COVID-19. So before I begin, I'd just like to give a territorial acknowledgement and to recognize that I live and work within the traditional territory of the Wendat, the Haudenosaunee, and the Anishinaabe people. And for 6 months of the year, I live within the reserve of Georgina Island. So what are some of the impacts of COVID-19 on mental health? So this is a bit of a recap from the previous presentation, but as we know very well, it's been a big disruptor to daily routines. And through this, we see increasing levels of stress, anxiety, and depression. We're also seeing a lot more emotional reactivity, panic buying, for some people even hallucinations. Right now, there's been this greater sense of fear, worry, and uncertainty among many people. One of the interesting things to notice with this is the reduced access to nature spaces. So from social distancing protocols, a lot of people have been physically cut off from nature, and this access itself is causing a lot of isolation and a lot of feeling of just unease. And this has been a disproportionately high burden on vulnerable populations, especially lower income people are specifically disconnected from nature and cut off from these green spaces. So what are some of the impacts of COVID-19 on students? Approximately 80% of students worldwide have been impacted by school closures. And this undermines future prospects, especially due to increased food insecurity and reduced access to literacy skills. And something to note that in developing nations, many students, especially girls, are unlikely to return to the classroom. And again, this is affecting vulnerable student populations even more. And it's important to recognize, especially at the University of Waterloo, because we have such a high percentage of international students, that these students are so far, based on the literature, more prone to mental health issues such as depression and are less likely to seek psychological interventions compared to domestic students. And this has led to more isolation, less access to public resources, and many have been unable to return home, either because of financial restraints, border closures, and so this feeling of disconnect and separation from family and culture has been extremely important to recognize. So some of the early benefits that have been noticed for mindfulness during COVID-19 are reduced stress and anxiety. And we see evidence from previous global health emergencies, including SARS and MERS, that contemplative practices have numerous benefits for reducing psychological distress. Another benefit of mindfulness is helping people develop better coping strategies and also to stay hopeful. There's a lot going on in the world with COVID and the election, and it's very easy for people to fall into despair. And through mindfulness practices, they found that people can cultivate a greater sense of hope and optimism for an uncertain future. It's also important to recognize that mindfulness can help you reprieve from suffering. So grief, people who have lost someone, people who are living in isolation, especially elderly populations, and also people who've been separated from their religious norms. So individuals who can't go to church or pray, or people who can't even have funerals or perform their religious rites for people who have died. Another important thing is to recognize how mindfulness can help nurture awareness in daily activities. And one thing we see is bringing awareness to how many times people touch their face or their mouth, and how many times people wash their hands and how they're washing their hands. In frontline workers, mindfulness has been really beneficial in helping to reduce burnout, compassion fatigue, and PTSD. Also important to help improve self-care, compassion, generosity, and gratitude. And in my own work, what I'm really interested in is the role of mindfulness to help foster resilience and enhance overall well-being and a lasting well-being for all people, not just mental health, but all aspects of health. So there's greater interest in bringing mindfulness into post-COVID-19 classrooms. And some of the benefits that are anticipated is a growing awareness and appreciation for alternative models of being and understanding. So for example, a greater respect of different perspectives like Indigenous. Also reducing stress, anxiety, and depression among pupils and teachers, and also reducing the stress and some of the different kinds of challenges that are faced in the classroom. It's also anticipated to help people develop better self-care and coping tools, so help students and help teachers reduce burnout. And part of this will be developing socio-emotional and cognitive capacities. So with this greater capacity to deal with complexity, and greater opportunity to deal with really challenging issues and to be with them without becoming reactive. So for example, climate change, this is an issue we deal with all the time, and this fosters so many feelings of fear and hopelessness and depression. How are we going to help students deal with these big issues in a post-pandemic future? And many scholars are suggesting that mindfulness is a great place to start. Another thing I think really important to notice is increasing reflexivity at all scales. So helping people recognize why they're thinking the way they do or what's triggering their thoughts, and also becoming more mindful of what we're teaching, how we're teaching, why we're not teaching things, and also what systems this knowledge can help support or dismantle. And becoming more mindful of how our learning is shaping us and the world. So this institutional level of mindfulness is bringing attention to the diverse needs of student populations, especially for screening at-risk students and determining the best kinds of support schools can offer, especially for at-risk pupils. And this was brought into awareness by some health providers who are saying that, there needs to be greater awareness and greater mindfulness for the health needs of LGBTQ+ college students. And so what does this mean in a post-COVID university? Something interesting that I also found was there's these greater calls for mindfulness, and it's not just in health, and it's not just in these really small spaces where we've seen mindfulness. It's really expanding into different industries. And what I think is really interesting about that is, for example, medicine, which is a huge contributor of greenhouse gases. It's 4.4% of global annual emissions. And most of this is coming from the United States, China, and the European Union. And doctors are saying, look, we're contributing to these lasting issues, these huge human health effects. So we have to be mindful of the way that we're doing things so that we don't create greater problems down the road, greater health issues for future generations. It's really interesting to note that risks to global health are increasing, especially viral infections. And COVID-19 is the third coronavirus in the past 20 years to pass between wildlife and humans after SARS and MERS. So increasing mindfulness is really important to help detect, prevent, mitigate, and adapt to these emerging threats. And action on COVID-19, both in our classrooms, our communities, and at the global level, require collaborative action and commitment to advance all levels of sustainability progress. So back to our students. Some of the programs and some of the different initiatives that are looking at implementing mindfulness in schools have found many different practices that are beneficial. For example, mindfulness-based breathwork or body movement, so yoga, tai chi, qigong, forest bathing, just getting students outside has been incredibly beneficial. Mindful journaling, mindfulness-based stress reduction, so MBSR, or CBT, digitized cognitive behavioral therapy, that has been especially beneficial with students to reduce fear, compulsive buying, hallucinations, and even paranoia. And a lot of these mindfulness-based applications have been exclusive and very expensive, but now because of COVID, everything's gone remote and it's become a lot more accessible to many people. So one of the main takeaways for students right now is mental health. And I think it's really important that we look at long-term healing. And the first step to this is really going outside. So I just thought we could have one quick moment just to bring our attention to what's going on in the world right now. And if it's comfortable for you, I thought we could all put our hand on our heart. And if you feel like it, close your eyes. And just bring your awareness to the happiness and freedom from suffering of all people. And just recognizing how that feels for you. And with that, I thank you so much for the gift of your time, and I look forward to the rest of the presentations. Thank you so much.
Hi everyone. I just want to confirm that my screen is visible.
It is visible. We can see you.
All right, perfect, thank you. All right, well, my name is Sarena Daljeet. I'm a master's student in clinical psychology at Waterloo. My project is looking at the changes in student well-being, particularly burnout and engagement, over the course of the pandemic. So chronic stress.
Your slides are no longer up.
Sorry?
Your slides are not up at the moment.
That's very strange. I'm screen sharing them. How about now?
Yes, perfect. We can see. Yep, perfect. Sorry, thank you. Go ahead.
Okay, perfect. Thank you so much for letting me know. All right. So the chronic stress from the pandemic has been linked to depression, anxiety, and stress-related physical problems such as headaches and insomnia in the general population. And university students in particular are at increased risk for mental health problems, alcohol use, and sleep problems during COVID-19. And due to social distancing restrictions necessitated by the pandemic, University educators and administrators are tasked with supporting student learning during a rapid transition to online learning environment. There's a need for relevant data on student well-being to inform these decisions, and the aim of this study was to track several dimensions of student well-being throughout the pandemic, particularly burnout engagement. And so here's a model for why it's important to study burnout and engagement. I'll go through the components one by one. So burnout is what occurs when the demands of academic life exceed a student's capacities. Students are exhausted, they're mentally and physically overburdened, and they develop cynical, disengaged attitudes toward their studies. Burnout leads to lower academic performance, and also, since stress suppresses the immune system, burnout leads to sleep problems, headaches, gastrointestinal problems, and respiratory illness such as colds, flu, sinusitis, and bronchitis. In contrast, when demands match the students' capacities, students experience engagement. They're energized by their work, they're dedicated, and they find their schoolwork absorbing. Contrary to burnout, engagement is associated with improved academic performance and personal growth and engagement. So when students are engaged, they're able to benefit from opportunities for personal growth. They become more autonomous, they master new skills, they develop meaningful relationships, gain self-acceptance, and find more purpose in their life and in their work. So our sample consisted of 600 university students taking introductory psychology courses at the University of Western Ontario and the University of Waterloo. So the pre-COVID sample was data collected a few years ago in 2014 from the University of Western Ontario. And for the COVID samples, we had data from both schools during different months, mostly due to logistics. And to explore the impact that COVID-19 has had on well-being in each semester, we used t-tests. And t-tests were used to assess whether each variable, on average, increases or decreases per semester. On to the results. This graph shows the mean levels of burnout according to month. So let's start with the good news. Student burnout hasn't altered, suggesting that students are equally able to meet the demands of academic life during the pandemic. It dips a little bit in September, naturally when classes have just started and deadlines are few, meaning less burnout. And in the last month, we do see a slight uptick, but otherwise it's quite stable. So this chart shows the mean levels of each component of burnout during each semester. For the components that have significantly changed between 2014 and the fall semester only, I've added a little percentage, and this just represents the change for the fall term. So we see again that burnout hasn't really changed, except for a slight increase in exhaustion by the fall term. We know that burnout predicts physical health. However, to understand the full picture for physical health, we have to look a little bit more closely at the subscales. So respiratory infections, such as cold and flu, decreased. That's a probable consequence of everyone staying indoors, socially distancing, as well as changes in the weather. Headaches and gastrointestinal problems are a little bit more interesting. So they increased very sharply in March, which is when we know that schools closed down and social distancing measures became very strict. So this suggests that these changes reflect stress-related changes due to the sudden onset of pandemic stress. These symptoms, thankfully, stabilized somewhat as students adjusted to the pandemic over time. Sleep differences also increased by 10% in the spring and summer terms. So we know that sleep is associated with stress. Sleep problems are associated with stress, and we know that sleep is also very tied in with depression and anxiety symptoms. And we know from previous studies that depression and anxiety symptoms have increased in particular for students during the pandemic, so this fits together. Sleep quality is also closely tied to exercise, and we also know that when people are staying indoors, they might be having less access to gyms or outdoor sports. The good news, however, is that sleep problems stabilized somewhat by the fall semester, by which time students likely may have adjusted. The most surprising and dramatic finding is that engagement has increased quite dramatically, up to about 50%. With fewer demands on their time from daily life and activities such as commuting, it's possible that students simply have more time to absorb themselves in their studies at leisure. And with less stress, they might find their studies more engaging and more energizing rather than draining. And so it's also plausible that being in school provides students with structure and a sense of normalcy, which might be a stabilizing force in students' lives. However, while engagement has increased, personal growth unfortunately hasn't. And so there are some important differences based on the subscales for personal growth. We can infer that online learning presents fewer opportunities for students to develop a sense of autonomy, form meaningful relationships, master new skills, gain new experiences that lead to self-acceptance, and feel that there's a purpose in their life and purpose in their studies. And accordingly, we notice that these components have decreased by the fall semester. Limitations in this study. So the sample size for the Western sample, the Western data, which was collected in the spring, was a little bit lower than the other samples. We had a sample size of about 70, whereas the other samples were between 200 and 300. So that might lead to some differences. In addition, there were some months where fewer students filled out the survey than others. For example, there were few participants in August due to the participant pool closing. In addition, some of the differences in well-being may also be attributed to semester. For example, we know that mood decreases as weather gets colder, and students may also typically be more involved in campus life when the weather is good, leading to more personal growth opportunities, even despite social distancing restrictions. In addition, proximity to exam time may have altered students' responses, as they may be feeling more stressed out and more overburdened while they completed the surveys. In addition, the time frames for some of the questions also differed. So when students were rating their level of physical health problems, they were rating it with reference to what they experienced over the semester. However, when they rated their levels of personal growth, they were asked to think about their whole university experience so far. Consequently, they may have been responding to these items a little bit differently. Another possible concern is that the Western sample actually included primarily first-year students, because at Western, introductory psychology students are usually in their first year, whereas at Waterloo, a range of students between their first, second, third, and fourth years participated in the study. And this is particularly important for personal growth because, again, the personal growth measure asks students to reflect on their university experience so far. So in sum, we know from this data that student engagement has increased drastically since the transition to online learning, whereas burnout hasn't changed. We also know that students have had fewer opportunities to develop their personal growth. Thank you for listening.
Great. Thank you to Chloe, Kira, and Sarena for your presentations on student mental health during the pandemic. Was really insightful and very interesting, and I've already got a couple of questions to reflect that. So the first one is for Chloe. Among the students without pre-existing mental health concerns, did their new symptoms reach the level of clinically significant change requiring intervention? And by extension, for those with pre-existing mental health conditions, is it possible it didn't change because they were already had so many symptoms?
Thanks for the question. So first, with respect to those students without pre-existing, they did not, on average, meet the clinical cutoffs. So that would suggest there's still, although they showed a worsening mental health, they did not meet sort of clinical thresholds. And if you saw, as I showed in the table, you know, the means at both time 1 and time 2 were consistently higher for those with pre-existing. So I think this underscores, you know, pre-existing were of concern before the pandemic. There's still a concern after the pandemic. Students without pre-existing seem to be showing declining mental health, but still not at the level where we would necessarily suggest clinical intervention. As for your question about sort of ceiling effects, I would say we don't have evidence for that because students weren't scoring at the tops. They were actually still fairly low. So yes, we had a good number clinical thresholds, but they still had a lot of room to increase. And in fact, same thing at the bottom level. So our students without pre-existing had room to decrease. And on some measures like the stress, you saw we were seeing declines in both. So I think that speaks sort of against regression to the mean and sort of ceiling or floor effects.
Wonderful, thank you. That was a really precise answer, and yeah, addresses the ceiling effect for sure. The next question is for Sarena. Are the data that are part of your study still being collected? Will there be data for November, December? They suspect that there may be more burnout in the second half of this term, possibly due to exams and possibly anxieties around Christmas season.
Absolutely, thanks for the question. And we are continuing to collect data over the next several semesters. And I definitely think it'll be very interesting to see kind of what happens as the weather changes again and as people adjust further and as the pandemic kind of stops and starts, as social distancing maybe starts again and then stops and kind of goes back and forth. And based on what we saw, I do suspect that there might be some more increases in stress as social distancing maybe kind of starts and then ends again.
Great, thank you. I have a question for Kira as well. When it comes to mindfulness and the research that you have done, have you seen any differences in the types of mindfulness techniques? Are some more effective than others? And have you seen any research about the suggested length and frequency of practicing mindfulness?
Yeah, thank you for the question. I think it's really context dependent. So whether people are doing mindfulness from a traditional Buddhist perspective versus a more secularized, medicalized and psychologized perspective. So it's pretty difficult to kind of compare the effectiveness between them. There's been many studies that have shown that in terms of efficacy for improving mental health, the amount of time that you spend in a meditative practice isn't as important as the frequency of your practice. So instead of trying to get people to commit to, say, a more classical Buddhist practice where you would spend several hours meditating, if we can get students to meditate for, say, even 5 minutes every day and cultivate a habit, we are seeing better results from that as well. One other thing that has been really important is just recognizing the difference of taking mindfulness practice off the mat. So not just getting people to sit and meditate for 5 minutes and then kind of letting everything go helter-skelter. It's kind of raising that awareness and then being able to take it with you off the mat into every day. And that's a really important thing that comes with that routine habit. And that's where we're really seeing the long-term positive effects of well-being.
All right, thank you for the answer. That definitely answers the question that I had. A little bit is a great start. Good to know. For Chloe, we have another question. Are there surveys in May 2019 and May 2020? Is there another survey planned? I would say anecdotally, a lot has changed since May when things may have looked more temporary. So I think they're wondering about how the severity, how you anticipate that might change.
I mean, that's the question. That is the burning question, is what's happening now. So yes, we hope to do more research and resurvey. My sense is that, return to academic year, a second wave of pandemic could be quite stressful for students. So yeah, we hope to do more data collection around that.
Okay. For Sarena, I have a question. When you were looking at all these different types of scales, the engagement, the burnout, the exhaustion, did you perform any sort of correlation analysis between these different scales to see if there was any interactions?
Yeah, so we did do some correlations. So we did manage to replicate the kind of network of relationships among the scales that I showed in the model earlier. So we did find that demands predicted burnout and that engagement predicted personal growth, which is consistent with what we found in the workplace literature, where there's been a lot more research on these scales.
Right. And are there any results you found a little surprising?
Actually, no. So the correlations were quite similar than what we would observe in a non-pandemic sample when we looked at the 2014 data, which suggests that kind of the network of relationships among these variables are pretty consistent, whether we're in a pandemic or not.
Okay, and like Chloe said, that may also be something that is susceptible to change as we go a bit further into the pandemic as well. So you'll be continuing these surveys, like you said, right?
Absolutely.
Great. Also for Kira, another question. You mentioned how it's important to be outside as part of mindfulness, and I was wondering if you know whether that effect is different for somebody in an area like Waterloo or a rural area versus somewhere like Toronto, where it can be a little difficult to be outside. It can be more crowded. It may not have as much natural environment.
Yeah, good question. So one of the biggest challenges right now with COVID that we've seen, and I'm coming from an environmental lens, is people who are being physically cut off from nature. It's really affecting, that alone is causing distress. So just yesterday I was at the dog park and one of the men there was saying, how can we have mental health during COVID when we're not allowed to walk our parks in or walk our dogs in nature? So it's a really interesting thing, and it is disproportionately affecting lower income people and people in urban areas who have limited access to green space. So I think one of the important things to recognize is people can connect to nature pretty much anywhere. It is a bigger challenge for people who are in these urban areas, but humans are now an urban species. Whereas we weren't for 10,000 years before. So it's part of our adaptation to learn how to connect in a very different notion of what is wilderness or what is wildness, and that itself is a practice. And so part of my research is looking at how we can help people connect to nature during COVID when we're so physically separated from each other and from the natural world.
And just thinking back to some neuroscience research in this sort of area that I remember from when I was an undergrad, at the time they were investigating how virtual reality tours of natural environments may help improve mental health, especially even for older adults who are in long-term care facilities and may not have mobility. So do you think that would be able to help fill in some of those gaps?
I think so. I am interested in looking at VR. I think one of the scary things is we need people to connect with nature to commit to protecting nature. And what's happening is we're losing nature faster than we can get people outside. So I think we will have no option but to rely on technology in some capacity to help us bridge that divide. And at the same time, if we can simultaneously enhance mental health while we're deepening our commitments to long-term well-being for all, then I think that that's a seems to be a win-win, and I'm really not seeing many ways to get around that because so many people just don't have the funds accessible to go out into nature.
Right. This ability piece is an interesting part of that, but for sure, enhancing well-being is still a worthy and ultimate goal. And for Chloe and Sarena, what are your thoughts on looking at these trends over time for those who are receiving different types of services? Like how can, similar to the virtual reality question, can online services be used to enhance mental well-being during this time?
Sarena, did you want to start or?
Go ahead.
Okay. I think it's a really interesting question. I don't know. I mean, from my perspective, one of the takeaways was that social connectedness is really important. And so if we have these sort of social distancing guidelines in place, how do post-secondary institutions then, support students in finding connection, at a distance or remotely or with students, in other countries? And so I think that's one of our take homes is what are schools doing to promote connectedness online potentially? We know emerging adulthood is a period where we see that increased need for affiliation. So how do universities support that in a safe way? So that would be my response to sort of more community-based samples. So I'd say our work doesn't specifically focus on those receiving clinical intervention and care necessarily. I think our findings could apply for, all post-secondary students. We need to support these affiliative needs in safe ways.
I agree with Chloe's comment, and I did actually want to add something. So in terms of, I can speak to psychological interventions a little bit. So the switch to online services has actually opened up some really wonderful doors for teletherapy, as there's suddenly been quite a drastic increase in the amount of research and the options for teletherapy. And this will help students who decide to complete their studies online in the future. And this will also translate to increased service access for individuals who are in more remote areas, for example, rural areas, and maybe even in other countries.
Right, perfect. Well, that concludes our Q&A session. I just want to thank all of you again, Chloe, Kira, Sarena. You all are engaging in amazing and such applied wonderful research, and I really appreciate your time here today. So thank you for that, and I am now going to pass off my moderating duties to Chris Perlman.
Thanks very much, Jerica, and thanks to all the great speakers again in the previous session. Really interesting stuff. So now in the next session, we're going to turn it over to Cindy Yeung. Cindy is the Vice President of Administration for the Graduate Student Association at the University of Waterloo, and she's going to speak to the Graduate Student Association initiatives to address student wellness and equity at UW. So Cindy's a PhD candidate with a background in human biology and health research methodology from U of T and McMaster. So now she's studying in the area of pediatric health related to pediatric PBPK modeling to advance knowledge of breastfeeding infant exposure to maternal medication. So really interesting research, but also really great, Cindy, that you're so dedicated and committed to the graduate student experience here at UW through your work with the GSA as well. So we'll turn it over to you, Cindy.
Thanks so much, Chris, for that really kind introduction. I'm just going to share my screen here. And hoping it's on the right slide.
Looks good.
Okay, great. So yes, thanks once again for that introduction. It's really great to follow up from listening to the COVID-19 impact on student wellness. Certainly taking home some of those learning pieces back with the GSA, especially with the mindfulness and even with the telehealth knowledge pieces. So I'm going to be talking about switching gears a bit. This is not a presentation on academic research really, but more about how the GSA is having initiatives to address this intersection between student wellness and equity at the University of Waterloo. So I hope you get a sense of activities of what we're doing at the GSA and to kind of spur some research ideas and how your research and the research presented here at the conference can have a relation to what I will be presenting now. So to give you a bit of background about the GSA and what we're about, and to give you a sense of how wellness and equity are very prevalent in our focuses, the GSA is a student organization that's non-for-profit, and we are the sole representatives of graduate students here at the University of Waterloo. Our mission is to serve the grad students with dedication and commitment to enhance the quality of our academic and social experience and promoting our well-being. Our vision is that we see the university where the interests of graduate students are protected, our voices are heard, and where grad students are able to realize ourselves optimally from social, financial, academic, environmental, and physiological barriers. We have 4 main values, and that's in transparency, inclusivity, integrity, and self-improvement. In terms of our strategic plan, you can again see these themes present. They were revealed at our annual general body meeting in August, and the 4 are listed here, which I'll discuss in more detail. I want to highlight some of the main points within our strategic plan throughout our 3 years and how equity and student mental wellness is involved. So in our first priority, we are looking into enhancing our advocacy and representation efforts to better student graduate supports. So this is proactively expanding our outreach efforts to engage community organizations, which include strengthening campus partnerships amongst faculty and staff associations. It is also to integrate grad student societies into our advocacy networks, again, strengthening those connections. So as examples, building connections with the African GSA, with the Indigenous Student Association, and with WUSA's RAISE as examples to improve those advocacy efforts. The second is to promote equity, inclusion, and diversity at all levels. So that is investing in research issues that are pertaining to anti-racism and equity, to engage with on and off campus groups to find synergies in advancing those equity and increasing visibility, and working towards improving and reviewing our own internal practices. We are also looking to building community to foster a sense of belonging for all graduate students. So that includes international students, those with needing accommodation needs, and those with disabilities. And working with those student groups that might have less visibility on campus. And finally, in pursuing excellence in our governance and service delivery. So that includes increasing leadership opportunities across all students of the University of Waterloo for grads, and as well as investing in continuously improving our services. And that includes our mental wellness services as well. And in highlighting our 4 political positions, again, just bringing to the forefront, one of them is we have 4 here. The first is to ensure ethical academic, employment, and social policies for grad students. So that includes having grad students freedom from unethical behavior, including discrimination, harassment, and abuse. Looking into mitigating barriers of pursuing graduate education in Ontario, and encouraging Waterloo to be leaders in sustainability. And fourth of interest as well is supporting student mental wellness and making sure that students are well supported in this area. I want to highlight our new organizational layout that kind of allows us to better meet the needs of graduate students in terms of equity and student wellness. So our team has grown throughout the years. We started with only 3 coordinators and now moving up to 11 coordinators, an addition of another VP position. And this allows, under our umbrellas now, to address, on the left-hand side, I'm highlighting Ashley Ryan as our student wellness coordinator, as well on the right-hand side, we have Erin Francis for our equity coordinator, and how I'll be highlighting how they'll be working together along with the rest of our team to address some of these concerns. We view equity as a nexus for all programming and work being done by these coordinators as a team, and therefore we're promoting equity for racialized individuals and also LGBTQ Two-Spirit Plus students. In terms of the intersection of student wellness and equity, as I mentioned earlier, we're looking at the left-hand side, which is meeting our strategic priorities to develop wellness programming to reflect unique graduate student needs, as well as actioning certain recommendations that we produced from our research contracts that were related to student wellness. So in a nutshell, this means unique graduate needs include, some of our graduate students are caregivers, or many of them are from other countries and living in their home country right now and working remotely. And different actions towards supporting our research contracts, which includes those for international students who might be experiencing discrimination. On the right-hand side, we have for equity, our goals are to foster intergenerational relationships with equity-seeking groups on campus, which I mentioned, as well as programming and events, and then really highlighting this concept of advocacy and wellness support, and how Ashley, our wellness coordinator, has these sessions, confidential advising sessions, and how we can incorporate equity into them when a student has discrimination concerns, for example, with their supervisor. How do we move forward as the GSA to help support these students? There certainly is an intersection between these two topics. And here I just want to highlight that this definitely takes more than just, student wellness and equity at the forefront. It is an intersection between, additionally with policy, reviewing our entire suite, and with the university's policy to see where we can improve on these two topics, as well as issues that international students face. Again, when I mentioned discrimination and cultural barriers, campus partnerships, so making those connections with the Indigenous Center and other groups on campus, including RAISE, and community development. So beyond just at the University of Waterloo, how can we make those connections with other groups so that we can incorporate equity and student wellness? And finally, I just wanted to leave us with examples of current projects that we are working on in relation to student wellness and equity. So we are issuing, as the GSA with GSPA input, a COVID-19 impact survey for fall 2020. And within the survey, we're getting at what's really concerning graduate students at this time, what stressors are they having, and how can we address those? And part of that is getting demographic information for race and ethnicity due to increasing evidence that some racial and ethnic minority groups are really disproportionately affected by COVID-19 in terms of health and many other aspects of their lives. It's also looking at the impact of self-isolation and physical distancing on mental health. So that's really, we'll be able to get some data on whether there's some intersection here, as well as experience with discrimination related to the COVID-19 pandemic. We are also issuing, in collaboration with WUSA, a regional housing survey. So that's based on what kind of issues undergrads and grad students are facing in terms of finding housing in the Waterloo and beyond region. And that also includes suspected discrimination by a landlord or property owner, for example, at the point of the tenancy process, and how that might affect individuals. And finally, we have recently supported, as a GSA, a mandatory mental wellness training for graduate teaching assistants so that we can not only be better in our terminology and noticing mental wellness and identifying different concerns across undergraduate students, but also our peers, and better addressing them as frontline teaching assistants. So these are 3 examples. We're very looking forward to continue our strategic plan in the context of equity and mental wellness. And so I thank you for your attention. This is definitely a team approach shown here on the right-hand side, and my contact information is on the left, and happy to field any questions.
Great, thank you, Cindy. As a a former grad student of Waterloo who used to sit on GSA, over 15 years ago, it's fantastic to see the evolution that's occurred in terms of the structure, organization, and supports being provided. Our previous concerns, pre-2005 used to be, what should we do with the grad house? And it's so much more than that now. Thanks to the hard work and dedication of folks like yourself. So We have a couple minutes for questions before our break. I'm going to go to the question board here. And it says, if a a question from Jerica. So if a graduate student wants to get involved in research or other opportunities pertaining to equity, how can they work or be supported by the GSA?
That's a really good question, Jerica, and I think there's a couple of ways to do this. First, in the sense that the GSA, we are issuing research reports out on specific topics that are of concern for graduate students. As I mentioned, we recently had one being published for international student concerns, as well as housing issues, and we will have soon one on sexual violence concerns. And we can see that if there's a call for concerns in equity, that would be a place where graduate students can be involved and receive this research contract and get paid to do this kind of work. And we would really value that kind of knowledge and experience from graduate students in that perspective. In other ways, in terms of any initiatives by graduate students, in terms of promoting equity and perhaps any events and initiatives that graduate students have on that front, we offer the Graduate Students Initiative Funds, which is the GSI. And that is funding for any sorts of initiatives, including those. So certainly that can move forward through that, as well as we are partnered with the GSBA's GSEF Graduate Studies Endowment Fund, which provides extra support and funding for that. So I encourage you to stay tuned to our social media and newsletters for different ways in which these kinds of initiatives can be supported, as well as, of course, if there's any sorts of research or other non-research initiatives that graduate students are interested in terms of equity and student wellness, feel free to email me or our office email, and we'd love to hear about them and how we can support that.
Wow, that's amazing. It's the number of supports and resources that people work so hard to put together. It's really fantastic. So I know we're just heading into a break here. So if anyone has any other questions related to GSA things, I believe you can probably post them in the Q&A for Cindy, or perhaps get in touch with her or the GSA directly. So thanks again, Cindy, for that great overview and really for all of your dedication and work towards supporting all of the graduate students at UW. So now we're going to head into a 15-minute break, well, a little less than that, 13 minutes right now if I shut up. So I would encourage everyone to be back on time at 2:15, where we're going to hear presentations from the Mental Health Commission of Canada on their standards for student mental health. Have a great break. So in this next session, we're delighted to have several special guests from the Mental Health Commission of Canada to speak with us about the Mental Health Commission of Canada's standards for student mental health. If anyone doesn't know, the Mental Health Commission of Canada is a pan-Canadian organization providing all kinds of resources and supports for promoting mental health across our population. With numerous priority areas, connections with policymakers, networks with diverse stakeholders, funding for research and other kinds of programming as well. So our speakers today are Sandra Coppert, who's the Director of Programs and Priorities with the Mental Health Commission, and Amy Fogarty, who's the Manager of Programs and Priorities with the Mental Health Commission as well. So I will turn it over to them.
Great. Thank you so much, Chris, for the warm welcome and introduction. And hello, everyone. We are thrilled to be part of the conference and the discussion today. So as mentioned, I'm Sandra Coppert, and I'm joined by my colleague, Amy Fogarty, to give you an overview of the newly released National Standard for Mental Health and Wellbeing for Post-Secondary Students. Now, that's a mouthful that I've managed to get straight. So we're hoping to inform you. Some of you may be aware of it, some of you might be hearing about it for the first time, to give you a high-level inside scoop on the standard, and hopefully have a little bit of time for a discussion or Q&A if needed. But let's just jump right into it. And so why a standard? I guess, part of the conference that you're a part of today and discussions I'm sure you've been having on an ongoing basis have already generated a lot of awareness in terms of the current state of mental health, particularly with students in the post-secondary sector, and the need to do more, and that certainly we're also looking at this now with the current realities, with the COVID context, as I guess I referred to it, and really just trying to understand the needs, the data, the research, the opportunities, and I guess also the gaps, and how to address those moving forward. So really this started about 2 years ago. We embarked on the journey to support the development of this national standard and understand, a lot of the current realities even at that time as well, and get it a sense that we know this isn't a new topic, so really a sense of where the research and information and realities were at that time, and there really was an appetite as well as the opportunity to develop a national standard, and that's what makes, I guess, this so unique, is that it's become this a national framework for any post-secondary institution to refer to, knowing that there's already work and obviously priorities on student mental health, but to have this national framework to refer to make initiatives and strategies and help provide a way forward while also addressing the great work that is already happening, and how can we leverage that even more so on a national level. So with that, the standard was developed. And what is the standard? It is a voluntary standard, and it's based on continuous improvement. So the important thing about this is that it is a CSA standard, so Canadian Standards Association, the CSA group, did develop this standard in addition to our championing it and many other partners and funders involved to support this work. So with it being voluntary, that also allows for the flexibility so that it's not prescriptive, and that it's there to be used in the unique ways that any institution can use it, and understanding that there is such unique, needs by each institution, as well as sort of the stage or the efforts that you're currently at in support for student mental health. So it takes all of that into account. So again, not being prescriptive, and also accounting for the fact that it isn't a checklist of things that you sort of just do once and you move on and now you're like, okay, done with that. It is based on continuous improvement, and that it is about, as we know and can appreciate, I think now more than ever, is that reality shift, and so that new opportunities and solutions and realities also come with that. And so that's where it's even more important, that flexibility and continuous improvement component, particularly when we're talking about a standard. And sometimes when you think of a standard, you don't associate with these things such as flexibility and continuous improvement, but those certainly are key pieces to this standard. And then just moving on to the next slide, we wanted to give a little bit of insight in terms of how this came about. So like I said, this was sort of a 2-year initiative that did start with sort of that baseline research and understanding of current realities and what was needed, and help to reinforce the need to invest in a national standard. And throughout this process, while it is a CSA standard, which then brought together, I think, with over 400 submissions, they, for any standard, do have a technical committee, and from those 400 submissions, we're able to create a technical committee of about 30 plus experts in the field. And and they're the actual writers of the standard, this technical committee. But our role at the commission and through a number of partnerships that we established along the way, we're also very much involved in not only socializing the standard as we continue to do now, even today, but really to help inform the standard. And then that's where we hosted a number of events or enabled dialogues and events with other partners to host, as well as doing an online survey and other consultations and a quite thorough public review process, all based on informing the standard based on 4 sort of key questions that then became the basis for discussion. And all sort of input that was gathered over that period was then fed to the technical committee to then review and consider in addition to their own expertise, and also leveraging a number of other resources and information that were gathered over that time. So a lot went into this, and we tried to approximate the total engagement, which I don't think even includes sort of just the higher level socialization of just driving awareness and now encouraging uptake. But this was really kind of reflective of the efforts that we put into informing, gathering information to then be used to consider when developing the standard that's now available. And with this standard, it is expected to help institutions in a number of ways. We've summarized sort of 5 key ways. We hope to, discover even more and understand the realities of these, now that the standard is released and being used. But certainly in terms of raising awareness and reducing stigma are always key to almost anything that we do at the Commission. But also looking at improving connection and belonging with learning communities, we know is important and has been factored into this. Increase on and off campus access to student support. So I know so much conversation was about that on and off campus supports, and that we really are looking at that sort of community perspective. Promoting life and resilience skills for school, work, and daily life. So much too is about looking at the whole student, and that there's so much more than sort of just campus life, and knowing that, there's a variety of realities that come with student life, including, looking at like the job perspectives and housing perspectives and financial that all play a role when we're considering student mental health. Certainly providing healthier and safer learning environments. And improving opportunities for student success. And I always pause on that one too, because it's such a almost its own conversation when we want to define what student success means, and know that that can be quite a unique definition for any individual or group. And so I think that's an important part of this too, is that of course, academic success is so critical, within the post-secondary world, but what true success can look like may vary just as well as how one's mental health or the supports needed for mental health can vary as well. So these are all important pieces. And so in addition to the standard itself, which is such the key resource, and we already mentioned that it's available and online, we knew that it could be a bit daunting for some, and we also didn't want to seem tone deaf to current realities with COVID, since the standard was sort of finalized around the same time that we were in this global pandemic. So we were sure to create a number of key resources to support the standard in general and also acknowledge the current reality. So I'm going to pass things over now to Amy to talk about that a little bit more.
Excellent. Thank you, Sandra. And it is a pleasure to highlight this key resource, which is the starter kit that was developed, I would say, over the summer, to really support post-secondary institutions in Canada in their early steps of considering aligning with this standard. So this kit is sensitive to the current context of 2020, which is a pandemic, and it offers helpful information on how institutions have been responding to the evolving needs of their student population. This starter kit was inspired by insights and input from interviews that were conducted over the summer with 6 post-secondary institutions, and I'll just name them quickly. That includes Dalhousie University, Concordia University, Carleton University, Fanshawe College, Red River College, and the University of Calgary. So we encourage everyone to download this free resource from our webpage. So please see the links in the live Q&A box to be able to access those links. And so the format of the starter kit is really an interactive PDF that we plan to update as appropriate. And it presents a variety of tools, templates, and resources, including some new tools that I just wanted to highlight briefly that were developed because of what was shared in the interviews. So those include a quick summary of the standards. So those who don't have time to go through it, I would encourage you to take a look at that quick summary, a customizable slide deck for getting support and buy-in, as well as an overview of what has changed at post-secondary institutions in the first few months of the pandemic. Throughout the starter kit, there are also links to the core, and that is the Center for Outreach, Resources and Engagement, which is an online community on the CSA website that houses other supportive resources, tools, and models to support post-secondary institutions in working with the standard. And so, as I just mentioned, in appreciation of the importance of supporting the implementation of this standard, this Center for Outreach, Resources and Engagement is that online collaborative community where post-secondary institutions can share resources and best practices to support their alignment with the standard. So you can find links to that via the starter kit. Additionally, what's coming soon around the standard and the work that we're doing to support its implementation is we've been supporting the development of a tool to support institutions in assessing where they currently are in relation to meeting the clauses of the standard and to assist in identifying opportunities as part of the journey of continuous improvement. And lastly, we're in the process of planning a workshop series to further support post-secondary institutions, so more info to come on that. And last but not least, before we sort of wrap up and mindful of time, I wanted to highlight a guide to student mental health during COVID-19 that can be found on our resource hub on our website. So we know that many students have been and continue to struggle with this pandemic that's amplifying feelings of stress and uncertainty. And this can take a toll on mental health and well-being, especially for students with underlying conditions or students who face additional difficulties due to disability, racial inequality, or systemic inequities, just to name a few. So this guide has tips on how to adapt to what's happening now, as well as resources on where to find mental health and financial supports. So we'll include a link to this guide in the Q&A box as well. So I'll pause there and just pass it back to Sandra to say a thank you.
Thank you so much, Amy, and thanks everyone for your interest in this standard. And even if you just go to our Mental Health Commission website, you can get more information, or there's also this email address if you want to be part of our mail out group. We don't overuse it, but just happy to stay connected in any way possible to address any questions that you may have. And if there's any time remaining, happy to open it up to any question or discussion.
Well, thank you very much to both of you, again, for taking the time to join us in sharing this work, but also for your leadership in ensuring that this work happens and can support campuses across Canada. I had a quick question, and it was great to hear you, Amy, mention that there's kind of a self-assessment guide that can help organizations see where they're at in terms of their implementation of the standard. And I was wondering, there's hospitals in Ontario, for instance, psychiatric hospitals that sort of do their own benchmarking and public reporting of different kinds of indicators of where they're at. And it acts as a bit of a community practice for quality improvement. Do you see that sort of thing happening, or maybe it is happening already across campuses, and in terms of what might be in the standards and how organizations can sort of track and report their progress?
Yeah, I'm happy to speak to that. We're certainly not the experts within the post-secondary world, but we certainly reach out to them for insights. The intention of this standard really is, as we've been positioning it as a self-assessment tool, so really is intended to be that tool for any institution to leverage, assess where they're at based on the components of the standard being in many ways aspirational, but then using it in the way that seems best suited for the organization for the institution, and then to track that over time to look for improvements and ways forward. But with it being national, as we mentioned, there's more and more opportunity, I think, based on communities of practice and other networks that exist and will, I think, continue to grow to learn from each other. But at this point in time, it's not meant to necessarily be a benchmark to start sort of comparing institutions.
Yeah. Okay. One more quick question. I know we're at time, but I think this is a good question. Are the standards catered to university administrators, or are there tools for individuals like staff and faculty and students to use and to implement?
Yeah, that's a great question, and like we encourage anyone to access the standard to familiarize themselves with what it is. I mean, it is really geared more towards developing sort of the strategies and initiatives more like institution wide. So that's where now we're kind of at that phase of gathering, I guess, through CORE, as Amy mentioned. We've already been gathering a lot of great resources that have already existed that seem to align with what's being referred to in the standard, and now starting to look for those opportunities to address gaps, such as the guide that Amy mentioned specifically for students, and understanding the needs for faculty too, and that there is the workplace standard that is being embraced by some post-secondary institutions that really looks more at the staff and faculty psychological health and safety, and the ideal, I guess, would be that it's all going to be referred to at some point, and that it really is the mental health for all. So that's where we do refer folks, even within the starter kit, to a number of resources that do exist. But the standard itself is that framework for institutions.
Yeah. Okay, well, thank you very much. Perhaps if the other questions come to mind, maybe we can send them to you as a follow-up. But Sandra and Amy, thank you so much for taking the time today to share this great work.
Yes, absolutely. Feel free to reach out, and thanks so much for your time, everyone. Thank you.
Okay, thanks. So great, so that takes us to our next session, which is going to focus on mental health interventions. So in this session, we have a few graduate students who are going to present some of their work. So Jerica Little, who many of you have already gotten to know through her great involvement in both working on this conference and sharing sessions today. So Jerica is a PhD student in the School of Public Health and Health Systems, and her work is looking at mental health in different kinds of care settings related to young and emerging adulthood. So her presentation is titled, my apologies here, Clinical Characteristics of Emerging Adults in Emergency Departments, Hospital, and Community Mental Health Settings. After Jerica's presentation, we'll hear from Robert Hicks, who's a PhD student here at the University of Waterloo, and in the Sensory Motor Integration and Neuroadaptive Plasticity Lab. And he's going to be presenting on investigating how exercise prevents mood disorders, links to motivation, emotional regulation, and negativity bias. So two great presentations coming up about some interesting research areas within mental health. So first, I'll turn it over to Jerica.
Hi everyone. Let me just bring up the slide. Okay, does that look good?
Yep, we can see that, Jerica.
Great, thank you. Okay. Well, hello everyone again. You have seen my face a lot throughout this conference if you've been joining, and frankly, it's a little weird to see so much of my own face as well. Not used to it. The reason would be that Chris had mentioned is that I work with the Committee on Student Mental Health as a graduate research assistant, and I am presenting on some inter-eye data with John, Chris, and Walter as part of my committee. So we're going to focus on emerging adulthood, which is a developmental period that is marked by many life transitions. So beginning around 18, we often see that many adults are moving away from home for the first time, taking on new responsibilities and becoming more independent, forming new relationships, starting careers, or, possibly becoming a student. So pretty relevant to the conference we're in today. And at the same time that all of these really rapid and serious changes are happening, we also see that a lot of psychiatric disorders are either at their peak in terms of their symptom severity or just beginning to emerge. In Canada, there was a longitudinal study that found that psychological distress in general was highest between the ages of 18 to 29. So while it's a concern at any age when there are some mental health issues, there's evidently a strong link between emerging adulthood and mental health, which is probably not a very shocking statement to anybody watching today. And yet, despite knowing that, there is relatively little information about emerging adults who are receiving care in psychiatric settings. Most research tends to be general population or within post-secondary schools. And this gap is important because recent Canadian data has shown us that emergency department and hospital visits are growing the fastest among emerging adults. So there was a projection model back in 2017 from the ED of a teaching hospital in Toronto, and they found that ED visits were going to continue to grow, and we were already outpacing the capacity of our current resources. This was before COVID, so that's definitely where we're at now from the data that we've been seeing. So it's a really, really serious issue, more so now than ever. And as part of addressing this problem, the Mental Health Commission of Canada, who just presented on their wonderful post-secondary standard before this, they had released a report in 2015 focused on emerging adulthood and mental health, and they noticed that there was a shortage of national data that could be used to inform clinical practice and policy guidelines. And we need that to be able to create a national strategy for providing care for emerging adults who are in a really unique time of their life. So the first chapter of my doctoral dissertation is really working to try and address some of these gaps. So there are two primary objectives of this first chapter of my thesis. The first was to look at whether there are some similarities and differences from the general and post-secondary student populations. So we see a lot of depression and anxiety and some substance use in those populations, but what else are we seeing in these care settings, such as like schizophrenia and bipolar disorder? And also, what are the differences between the care settings themselves? And for the second objective, there is some debate in the literature on emerging adulthood about when the age should end. So if that's 24, 25, 29, 30. And this study won't, provide a definitive answer to that question, but it can contribute to how we can use age cutoffs for research in this context. And it can also tell us about how resource needs might be different when you're a little younger versus a little older. So for example, we do find that substance use tends to be highest between the ages of 18 to 24 before tapering off of it, which was also shown in the two studies we had on substance use this morning. So I will be using INTRI data, which we have discussed already. It was one of the data sources mentioned in the data source panel. To provide a brief overview, they are healthcare assessment instruments that are designed for specialized settings, like you can see in the map on the left-hand side. But they're also designed to be compatible so that we can compare settings and look at how people are receiving treatment and changing over time. For my thesis, I focused specifically on 18 to 35-year-olds. And I was looking at the first episode of care that we had, so trying to look at people as soon as possible who were entering care settings. So I have psychiatric hospitals with the IMH, and this assessment was mandated back in 2005. So that means for every adult who's admitted to an inpatient unit for at least 3 days, they have to be assessed with this instrument. So it is a fully representative sample, and we also have one hospital in Manitoba and two in Newfoundland who are providing some data. For community mental health, I have a couple sources from Ontario as well as Newfoundland again, and I had just over 2,500 people. And then finally, for emergency departments, I had some data from Niagara and the Chatham-Kent region and had about 1,300 18 to 35-year-olds. And I'm not going to go into all of these. I just wanted to highlight some of the different areas that I look at with these assessments. The socio-demographic variables that I'll show some today are really related to pinpointing those emerging adulthood characteristics. And we'll also be focusing on the psychiatric symptoms, so diagnoses and clinical symptom scales and substance use, as well as the clinical needs, which are those prospective risk scales. About the severity of self-harm scale earlier today. That'll be one that we look at, as well as just some clinical assessment protocols that tell us a little more about what's going on in a person's life, so issues with sleep, social relationships, trauma, and so on. So to start, we're looking at the clinical symptoms and diagnoses in care settings between, and this is for the 18 to 30-year-olds. So we find that mood disorders are the most prevalent in all settings. In psychiatric hospitals specifically, there are more diagnoses of schizophrenia and substance use than in other settings. And in both hospital and community settings, we're seeing anxiety and personality disorders are typically comorbid to something else, meaning that they're not the presenting or the most important diagnoses. But if we look specifically at the emergency department, we see that both of those disorders are just as often the primary diagnosis as the comorbid. So this might mean that they're less likely to receive follow-up care after visiting the ED. On the right, I've just chosen a few of the clinical symptom scales to highlight, as well as the 3 risk scales. So depression and social withdrawal were both higher in community settings, though in all cases, moderate to severe scores were observed in over 40% of the population. So a really serious problem for a lot of people. Positive symptoms of psychosis like hallucinations and delusions were really highest in the hospitals, which kind of corresponds with having a greater number of schizophrenia diagnoses. And we also found that all of the risk scales were higher in the hospitals, especially that severity of self-harm scale. So just over 40% scoring really highly in the hospital for this particular problem. Overall, there weren't really a lot of age differences that we observed across the settings, possibly because admission criteria makes these populations a little more homogeneous by design. But we did see in psychiatric hospitals that the 18 to 24-year-olds had more of those characteristics of emerging adulthood. Notably, about 40% had some sort of post-secondary education, and over 40% of the older age groups did as well. We also saw that the 18 to 24-year-olds had more cannabis use in the last 30 days, which is similar to what was found in the substance use presentations this morning, as well as a higher risk of self-harm. And that was fairly similar in the ED. In community mental health, we see the same trend for emerging adulthood characteristics. Just over 30% of 18 to 24-year-olds were currently enrolled in a post-secondary program at that time. So it's a pretty significant part of that population. We also found that substance use again was highest in the youngest age group. Diagnoses of schizophrenia were lower, and I think that's possibly just because maybe these people are receiving these services a little bit later in life. So I'm not going to go over this too much, but the 2nd and 3rd chapters of my dissertation are focused on creating an anxiety scale, since we did observe a number of primary diagnoses in the ED, as well as comorbid anxiety in all settings. And at present, it's not a scale that we have in the INTRI instrument, so it would be certainly a very useful thing to have given the context. So on the left, we have the prevalence of indicators that are currently in the instrument and that are grouped under anxiety. In each case, the indicator is higher among those with an anxiety disorder than without one, so that's the expected direction. Anxious statements were the most common and are present in almost half the sample even without an anxiety disorder, so fairly common, whereas on the other end of the spectrum, compulsive behaviors were pretty rare. And then on the right-hand side, I just have one of the confirmatory factor analysis models that I ran. And what it's showing are that the somatic items that are included in almost every anxiety scale I've looked at, they're not performing as well. And that's possibly because of some age differences that we're going to look into. But overall, the anxiety items do perform pretty well. And we are looking to refine this. So by no means is it the final scale, it's just sort of where we're starting. So to summarize the results, we do see some similarities and differences related to setting, which just makes the point that we can't generalize one population of young people to everybody. We do have to look at how things are working in different settings. So hospitals are very acute, whereas community tends to be more chronic issues. There weren't a lot of differences related to age, though there were those emerging adulthood characteristics, which would still be important for treatment. And I wanted to take a little bit of time to reflect on anxiety in the ED, because we do see people with anxiety disorders that are the most important disorder there relative to others. So if they're not receiving inpatient hospital care and they're not as often seen in community settings, it's possible they're not getting follow-up treatment after going to the ED. And what this looks like really is someone who's going because they have anxiety and maybe they aren't sure where else to go at that moment, only to be sent back home. So that's obviously a very frustrating experience for the person who is seeking care. And at an extreme, sometimes you hear people who are asking, you know, what do I need to do to be taken more seriously, which is extremely alarming to hear. But I also found in my literature that the ED can be a first point of contact for emerging adults who are entering the mental health care system for the first time. So if they're receiving this sort of disengagement right at the very beginning, that can lead to a pretty poor prognosis of their care engagement over time. And the literature has noted that lack of engagement with psychiatric services does tend to be a really big problem in emerging adults relative to adolescents or people who are older. So it's really important that we, yeah, I know, I've got just one little paragraph. Just the ongoing research that where we want to take this is to look at outcomes across different settings, including post-secondary schools. We want to be able to predict who is at high risk of going to a hospital and how to ideally prevent that from happening in the first place. And when it does, how we can improve care for them when they come back. And also to look at how treatment interventions affect these symptoms over time and how we can use that to create care plans that are customized to the individual and take the burden off of the young adult or student who needs to navigate these resources themselves. And so just my references, and now I will pass it on to Rob. Thank you.
Thanks very much, Jerica. So we're going to pass it over to Robert Hicks, who's looking at investigating how exercise prevents mood disorders.
Okay, can everybody see and hear okay?
Looks good.
Okay, great. So thank you for the opportunity to speak today. And I'll be talking to you about my research on how exercise prevents mood disorders. So in popular culture and pop science, the positive mental effects of exercise are thought to be explained by the endorphins hypothesis, commonly associated with the elusive runner's high that is talked about but rarely experienced across individuals. Simply put, it's thought that exercise increases endorphin release in the brain, which leads to decreased pain perception and increased happiness, euphoria, or any other word you want to put in there. However, it's becoming clear that this explanation is insufficient, as not everyone experiences this effect post-exercise, nor is high-intensity exercise necessary for required for preventing mood disorders. So the influences of emotion are rarely one-to-one, and it's often more complicated, which is why I'm interested in this research. So important to this work is the fact that the brain is plastic, meaning it changes throughout our lifespan. And this is the mechanism for how we learn, create memories, and adapt to our environment. However, plasticity is not always beneficial. So for example, when animals are exposed to repeated aversive stimulus, it results in an animal model of depression called learned helplessness, where they no longer try to actually avoid the aversive stressor. Interestingly though, animals, and particularly rats, that have the option to voluntarily exercise between stress exposures do not exhibit the same learned helplessness behavior. And this is important as forced exercise does not lead to the same adaptation as it may be in aversive stimulus itself. In humans, psychomotor activity and depression are linked such that people who are more physically active have lower rates of depression, while those who are depressed move less than their healthy counterparts and also show decreased levels of neurotrophins, which are chemicals that promote plasticity in the brain. There's large bodies of evidence to suggest that on average, human brains are more affected by negative than positive stimuli, situations, and processes. However, this negativity bias is likely due to evolution, where it's better for our survival and reproduction to be concerned with threats and problems as opposed to be constantly sitting in a state of bliss. However, negativity bias can be larger in people at risk or who currently have depression. This negativity bias is repeatedly shown in the lab in simple behavioral tasks like the emotional Stroop task, where negative words like the word funeral, where the subject has to say the color of the text, in this case green, leads to a slower response than if the word is a positive word like party, or saying the color red in this scenario would take less time than saying green and funeral, which indicates a interference effect of the negative valence of the word. It's also been shown in physiological measures of the brain measured using electroencephalography, which measures brain waves, like the N2, which is a negative deflection event-related potential shown here. And in this example, the negative has a larger negative deflection than the positive, showing a physiological negativity bias. So one area of the brain that's highly implicated in this process, or in these processes, is the dorsolateral prefrontal cortex, marked here in the blue. So this area is thought to be highly cognitive, and its major role is in goal orientation and motivation. And it actually integrates our emotions in relation to these goals and can further influence downstream emotional processing. Importantly, its roles are asymmetrical between the two hemispheres of the brain, such that the left is thought to relate or regulate negative emotion for approach motivation processes, and the right is thought to regulate positive emotions for withdrawal motivation. Consequently, it's been shown repeatedly that across fMRI studies and EEG studies that individuals with or at risk for depression show a asymmetry between the two hemispheres, where the left dorsolateral prefrontal cortex is less active than the right. So to summarize, while there are other risk factors in developing depression, important to this work is the decreased psychomotor activity, increased stress exposure, increased negativity bias, and decreased left dorsolateral prefrontal cortex activity, and trying to link these concepts. But I won't be concentrating on the increased stress exposure, as these are difficult things to control in the lab. So for my MSc and PhD research, my MSc aimed to answer the question, can we simply move, or do we need to actually exercise to increase the activity of the left dorsolateral prefrontal cortex? Do brain measures of attention reflect a negativity bias, as shown in previous literature? And does this negativity bias relate to dorsolateral prefrontal cortex activity between individuals? Does modulating the activity of the left dorsolateral prefrontal cortex with brain stimulation influence the negativity bias shown in these brain measures? And does exercise influence measures of negativity bias along with the left dorsolateral prefrontal cortex activity? And finally, a clinically relevant question is, are exercise and brain stimulation synergistic in their effects of these processes? So in my master's work, I tested moderate intensity cycling exercise and zero load cycling to see if sustained movement was sufficient to increase the activity of the left dorsolateral prefrontal cortex. And I used a measure called frontal alpha asymmetry, which is a ratio between alpha brainwaves between the left and right frontal electrodes measured using EEG. And alpha waves are a correlate of overall cortical activity. So it's a ratio of the cortical activity of the left versus the cortical activity of the right. So the results repeated previous literature in the exercise conditions such that compared to pre-exercise, the frontal alpha asymmetry score increased at 20 minutes to 40 minutes post-exercise. And an increase in this score indicates an increased activity in the left hemisphere. However, the no load movement condition, where they were moving but not exercising, there was not a significant increase in this measure, indicating that there does have to be some demand or some challenge in the movement to elicit this effect of changing the activity of the left DLPFC. So for my PhD work, my first completed study answering, do brain measures of attention reflect a negativity bias? The answer is yes. So when we show subjects positive and negative images in a cognitive task, a brainwave called the N2 related to attentional processes shows a greater response or a more negative response in the negative images versus the positive. And this is reflected in this brainwave peak here. But this is the averages across all individuals. So importantly, this may vary between people along with their left dorsolateral prefrontal cortex activity. So when we correlated the negativity bias within this N2 measure with the activation of the left dorsolateral prefrontal cortex, what we found was an increased negativity bias in this N2 measure positively correlated with less left dorsolateral prefrontal cortex activation in the negative compared to the positive images. So this suggests a link, but we don't know the causal link between the two, as it might be mediated some other way. So in my upcoming studies in my PhD, I hope to answer, does modulating activity of the left DLPFC with brain stimulation influence this negativity bias? So what I plan to do is use transcranial magnetic stimulation, which is a brain stimulation technique that uses dual electric coils to produce relatively focal magnetic fields. And these magnetic fields permeate the skull and induce neuronal activity in the underlying cortex. So a type of repeated TMS called theta burst stimulation utilizes a specific pattern of TMS pulses to induce short-term excitability changes in the targeted region. So with this technique, I'm planning on using these contrasting techniques to increase the activity of the left dorsolateral prefrontal cortex and also decrease the activity of this area to see how it influences the N2 negativity bias that was shown in my previous study. Importantly, the intermittent theta burst, or the ITBS, is to the left dorsolateral prefrontal cortex is a common or a more commonly used alternative to electroconvulsive therapy in depression. So for my final PhD study, I'll be aiming to answer, does exercise influence the measures of negativity bias along with the left dorsolateral prefrontal cortex activity? And importantly,
one more minute.
Okay. Is exercise and brain stimulation synergistic in this process? So with the ITBS, it increases cortical excitability, which modulates the synaptic efficiency between neurons, and it's able to affect the targeted region as well as the network that it connects to. The aerobic exercise can increase creation of new neurons and plasticity molecules that promote a more plastic environment within the brain, but this is a more diffuse brain-wide effect. So when we combine these two, it's possible that they may have a synergistic effect, but importantly, they both independently can influence this frontal asymmetry or left dorsal prefrontal cortex activity, which may synergistically regulate negative emotions and negativity bias. And thank you.
Great, thank you both for that. You might have noticed I'm not Chris Perlman. It's not that Chris has aged rapidly this afternoon. Chris had to attend to something else, so I'll take over for the Q&A session. Rob, maybe I'll start with a question for you. I was interested that you chose cycling as the exercise intervention to use, and I'm trying to sort out what about exercise is good when it comes to mental health. So I love going biking in the summertime. But you know, weather's gone ugly except for maybe this weekend, so I've had to move to indoor riding with like a Wahoo simulator and all that, and it's just not as fun. So what I'm trying to understand is what's the benefit of exercise for mental health? Is it the actual physical task of the work that you're doing, or is it the other things that go along with it? So in biking, it's being able to go outside and enjoy the fresh air and the physical environment versus doing it indoor. It feels more like work. If I think of something like tennis, which I play, it's socialization with friends while we're playing. So which is more important, the physical aspects or the other things that come with exercise?
It's likely complex and multifactorial. Like engaging with others and getting that social aspect may also have further improvements on top of the exercise itself. But the act of voluntarily exercising itself and undergoing a stressor, a physiological stressor that's controllable, that is actually able to resolve, and kind of this, it can affect these more automatic processes of emotion that may not be necessarily immediate or consciously experienced by the person in the moment, but over time may actually to affect more automatic processes, like you know, whether we have a larger negativity bias that's more automatically processed within the brain than what we might be consciously aware of. So it's more this, getting this, it's a stressor that's controlled or involuntary within the subject that can cause these plastic effects throughout the brain and actually decrease our stress response further down the road when we experience any other type of stressor.
So the other question for you is about the nature and intensity that's needed for a mental health benefit from you, what you know about that literature. So is there a minimum threshold of exertion you've got to go through in order to see mental health benefits is the first part? And is there a difference between sort of cardiovascular exercises versus weight bearing? And when you look at the aging literature, the folks in the kin department are pretty forceful in saying if it's not weight bearing, it's no good.
Right. In terms of the mental health benefits, in terms of the absolute minimum, in terms of having a mental health benefit, I would say low intensity in, like there's evidence that even just moderate, like low intensity walking, for example, even on a treadmill can have positive mental health effects. But it's a matter of, you know, sustaining that over a period of time and getting repeated exposure to it. So it's a bit complicated, and it depends also on how sedentary the person is already versus their experience with exercise in the past. But on the short answer is some will give you a benefit as opposed to none. But in terms of intensity and this dorsal prefrontal cortex activation question, the reason I did the no load movement was a couple of studies showed that it didn't matter if you did very low load exercise or high intensity exercise, you still had this shift in this frontal asymmetry measure. So I was like, well, is it even the exercise then? Is it just the fact that you're moving, which is shown to have a link to depression? So cycling was an easy way to get a low load movement intervention to test that. In terms of,
so some suffering is the road to joy, is what you're saying.
Yeah, and yeah, in a sense, right? Because it's that physiological stress that, you know, often is activated in emotions and emotional responding to stress, but it's controllable by the subject and doesn't correspond with these emotional. It's not emotionally triggered and it's controllable by the individual.
All right, thank you. I'll have one quick question for Jerica, then we'll hand it off to Mark Farrell for the next session. So Jerica, you highlighted research results in healthcare settings. Among the recommendations in the committee in the PAC SMH report were to establish a complex case management team. What are the implications of your research for how mental health services in campus should articulate with mental health services throughout the healthcare system?
Okay, well, we really do have to start the next session, so I won't really be able to provide an answer beyond. We do have a complex care case manager at Campus Wellness now, following the recommendation, and I believe that she has a great handle on tracking student progress throughout care settings and can use data, hopefully, to inform how that's progressing.
Well, I think the broad issue is that we've got very robust mental health services that we're providing on campus, but they should fit in with the broader mental health system that's out there. And your research provides some opportunities, I think, for how to think about that. Okay, so we're going to hand off to our next facilitator, Dr. Mark Farrell from School of Public Health and Health Systems. And Mark will introduce our next speakers and facilitate the Q&A section. Take it away, Mark.
Great, thank you, John. So we are in the home stretch now, everyone. Our final session is mental health promotion in health education, and we do have two presentations. The first by Christine Zaza and Ryan Yeung, assessing Waterloo's first undergraduate course on mental health literacy. Did students' attitudes change over time? And then our second presentation by Kristen Archbell, entitled Social Anxiety in University Communication Preferences and Pedagogical Strategies for Educators. So we will pass it off to Christine and Ryan now, and then Kristen, if you don't mind, just continuing with your talk right afterwards. We'll have the Q&A at the very end, and monitor the chat. I will let you know when you have 2 minutes left.
Thank you, Mark. I'm going to start sharing. If you can just confirm that my slide is being seen. My title slide.
Yes, we can see your slide. Thank you.
All right, that's great. Okay, thank you. So in this presentation, we're going to describe a new mental health literacy course that is open to all undergraduate students on campus and is offered by the Faculty of Applied Health Sciences. So first, I'm going to take a couple of minutes and describe the course, and then I'm going to turn it over to Ryan Yeung to present the findings of our pre-post study. So here's a brief history of AHS 105. In December of 2018, I approached the AHS Interim Dean, Paul Stoley, and the Associate Dean Undergrad, Leanne Ferris, with the idea to offer a new course on mental health literacy. At that time, I also spoke with a number of undergraduate and graduate students about this course, this potential course, to get their perspective on what they might like to see in it. And over the course of 2019, the idea for the course was approved at the faculty level, and as well, it was approved at undergraduate senate. And then in November of 2019, at a wellness collaborative meeting, Ryan Yeung approached me and he proposed doing a study on the course. And while I had thought about doing that, I didn't really do anything more than think of the idea. So really Ryan spearheaded the study, and it was with his enthusiastic drive that we put together the study design, and we applied for ethics in December of 2019. And then at the beginning of 2020, I taught the course for the first time, and Ryan conducted the pre-post study. So here's a look at that first class of 2020. And I want to just mention that we had a maximum enrollment of 100. So as you can see, we had 106 students at the beginning of the course. So we exceeded maximum enrollment rate at the beginning, which was really encouraging. Much to my surprise, there were about half of the students in the course were fourth year and above. And as you can see in the pie chart, about 60% of the students were from applied health sciences, and 20% were from arts, 10% were from science, and about 3% were from environment and from math. At that time, this course was not on the approved list of electives for engineering students. Very recently, that has been added. This course has been added to their approved list. So we had 5 of the 6 faculties represented in the class, which was pretty good. So here's a look at the design of the course. So I broke down the content into 3 main units. In the first unit, we covered fundamental concepts. So for example, the 2 continuum model. And in the second unit, it really focused on responding to mental health needs. So needs in the self as well as needs in others. And here's where we talked about help-seeking behaviors, stigma, intersectionality, and other important topics. The third unit really drew on positive psychology literature, and it was really focused on concepts such as resilience, strengths-based resilience, and emotional intelligence, and other similar topics. There were 2 themes in the course. The first theme was looking inward. So this is where students applied course concepts to their own mental health and well-being. And they mostly did this through their personal mental wellness plan, which comprised about 25% of their final grade. And then another theme was looking outward. So similarly, applying course concepts to other people's mental health and wellness. And students mainly did this through their group project, which was a mental health literacy project in their campus community. And this was also a large project in the course. It was worth 25% of their final grade. Assessments also included 3 unit tests, which comprised 40%, and also students had a lot of choice to complete 7 of 15 possible learning activities. Just to give you an example, one learning activity was to go visit counseling services and take a selfie at the door and take a look at the posters on the wall and then answer some reflection questions. And that was a really eye-opening activity for a lot of students who had never even been to counseling services before. So it really helped to break down some barriers. This is an example of a group project, and I won't go into detail, but the groups did an amazing job. Some focused on reducing stigma on campus, others focused on mental health awareness in athletes and help-seeking behaviors, and really they did a fantastic job. I want to acknowledge the guest speakers in the course because the guest speakers really greatly enriched the course, and the students really appreciated the guest speakers. And you can see that we had guests from the Faculty of Applied Health Sciences, and we also had guest speakers from outside of the Faculty of Applied Health Sciences. So now I'm going to turn it over to Ryan, and he is going to walk you through the pre-post study.
Hi everyone, so I'm Ryan. I'm a PhD student in psychology, specifically cognitive neuroscience, and I'll be talking about the evaluation portion of this. Right, so all students in AHS 105 were eligible to participate, so all of them were sent invitations, and they were sent invitations at 2 separate time points. So one at the start of the course, so before any major content had been covered, and then one at the end of the course, so after the final exam, but before any final grades had come out. So we're sort of at the mercy of whoever wants to participate. So we ended up with some subset participating at time 1, another participating at the end, and then we were left with 10 individuals who participated at both time points. So all the analyses that I'm about to show you are done within subjects with those 10. But if anybody likes stats as much as I do, I'm happy to talk about multiple imputation that we did to bump up the sample to 40. It replicates everything I'm about to show you. Okay, so some basic demographics were asked about, so things like age, gender, year of study. We also asked about course feedback at the very end of the study. So after everything had been done at time 2, that's when we asked them about course feedback. And finally, we also had measures of current mood at both time points, just to see if that had any influence on any of other ratings. And just in case you're interested, it did not have any significant impact. It was not sort of pushing around anyone's attitude ratings. Okay, so for this next section, I'm going to talk about some of the key measures that we were interested in. So these are the attitudes that should be changing along with sort of mental health literacy literature. So first, we have roughly grouped as attitudes toward mental illness. I won't be talking about any of these in super great detail, but I'm happy to answer questions about them later. Basically, this first version is these two measures look at ability to sort of recognize clinical level issues, but also willingness to serious health concerns. This second group is called stigmatizing attitudes. So sorry, I think my internet is being a little choppy here, but I will quickly just flip off my camera to try to assist in that. Okay, sorry about that. So this next section is looking at perceived stigma from both the self and from others. So feeling inferior if they asked a therapist for help versus others seeing them as inferior. And then finally, our third section is looking at attitudes toward help seeking. So willingness to seek help and also perceived barriers that they might have experienced in their past ventures. Okay, so diving right into the data, we can see that we're looking at attitudes toward mental illness. Again, I'll just reiterate what we're looking for, T1 versus T2, within the same individuals at the start versus the end. And we find no significant differences from time 1 to time 2 with these people. And we think this might have to do, again, with potential ceiling effect. The full range of the scale is shown on the y-axis, so maybe these individuals are walking in with pretty high knowledge to begin with, so we may not have been able to see a shift upwards. So our next graphs looking at stigmatizing attitudes. So again, you see no significant difference from time 1 to time 2, but again, the opposite problem. It looks like people who are walking into the course are already having pretty low stigma, which is positive, but unfortunately it reduces our effect to see any change downwards. All right, so looking at looking at help seeking, we see a significant difference here. So large effect size, we see a difference by time 2, where individuals appear to be more willing or able to seek out mental health services. And one especially positive thing about this is that this scale actually predicts whether or not individuals are sort of more likely to actually seek out help later in life. So that's something we really encouraging and we'd like to replicate further. Again, no significant difference when we look at actual perceived barriers that they think they've experienced. Okay, so looking at some qualitative data really quickly, we see just a histogram of how people rated the course. So most people overwhelmingly find it valuable. Most people saw it as extremely valuable to them. And again, looking at some open text comments that people were asked about. They are just asked, or what would you like to tell us about the course? And totally unprompted, these people are saying really positive things. They thought it was a safe learning environment. They really liked being able to focus on mental health literacy for a whole term. They felt that their health was actually more important than getting a grade. And really nicely, they were talking about how if they had taken it earlier in their career, this would have been great to prepare them for the stresses of university. Okay, so we're really encouraged by the findings today. First of all, that it seems like this course is associated with significant improvements, specifically with help seeking, but unfortunately we weren't able to find evidence for other types of skills. So we're hoping to replicate this kind of pattern in a later offering of the course. As well, we see that people really do seem to like the course. And finally, that we want to encourage this kind of empirical evaluation on a greater scale.
So I'll just talk a little bit about the future of AHS. So as you know, the first offering was in the winter. I made some revisions to the course content and a little bit to the design over the course of the spring term. And I am now co-teaching the course with Gitanjali Shanbag, who is a PhD student in engineering. And we're teaching it this fall remotely with 101 students. At the Center of Extended Learning, I am working with colleagues to develop the course as a fully online course. And Ryan and I are currently seeking some funding to repeat and expand our study in future offerings of the course. In addition, the faculty of AHS is exploring ways to increase capacity so that more sections of AHS can be offered. And that's all we want to present today, and we hopefully will answer some questions when it comes time. Thank you.
Thank you, Christine. And thank you, Ryan. If we can get Kristen's slides up, please. Kristen, you have the floor.
Hi, everyone. Thank you. I hope everyone can see my slides.
Yes, we can. Thank you.
Okay, perfect. So my name is Kristen. I am the Educational Research Associate at the Center for Teaching Excellence, and today I'm going to talk to you about social anxiety in the university context. So first, we'll cover some basics about social anxiety, which can be conceptualized as distress and feelings of discomfort when meeting and talking to unfamiliar people. So milder symptoms of social anxiety materialize as social apprehension, often occurring in response to social evaluative situations. And as the severity of social anxiety increases, social fears may become disabling and pervasive. So there's 3 different domains of symptoms associated with social anxiety, including physical symptoms. So for example, increased heart rate or blushing. Cognitive symptoms, including a blanking mind or distorted thoughts, as well as behavioral symptoms, including leaving a particularly stressful situation or avoiding situations altogether. So approximately 21% of Canadians experience heightened levels of social anxiety, with about 8% meeting the diagnostic criteria for social anxiety disorder. And it's quite prevalent among the university population. Central concerns of individuals with social anxiety includes fears of being inarticulate, sounding unintelligent or boring, or not knowing what to say or how to respond within different social interactions. These central fears, considering these central fears, it's understandable that individuals with social anxiety would struggle in the educational environment, as students are often expected to engage with unfamiliar peers or participate in classroom discussions, as well as give oral presentations and so on. So it's been found that students who experience social anxiety also have anticipatory anxiety prior to learning, fears of negative evaluation within the classroom, physiological and cognitive indicators of anxiety while in the classroom. They quite often experience shyness or embarrassment during learning activities, and experience post-event rumination. So this means they often dwell on or pick apart events that occurred that they view as negative. So generally speaking, social anxiety is negatively associated with engagement, is associated with lower rates of retention and increased exam failure, as well as difficulty in communicating with others. So I'm going to briefly review a study that I conducted that kind of lays the foundation for the current research. So on the screen here, you'll see a conceptual model linking social anxiety with communication, so communication with instructors and peers, to 3 different academic experiences, so engagement, classroom community, and course satisfaction. So among the results, social anxiety was negatively related to communication with instructors, as well as student engagement and classroom community, so those feelings of connectedness with others, so with the instructors or with other students, as well as course satisfaction. And communication was found to partially mediate the link between social anxiety and all 3 of these academic experiences. So communication with peers and instructors is an important underlying mechanism in the connection between social anxiety and academic experiences. And therefore, we need to find ways to enhance socially anxious students' communication, as this may lead to better educational experiences. So this brings us to the current study and kind of the main questions that we need to think about. So why do communication barriers exist for socially anxious students, and what can we do to start breaking down these barriers? To address these questions, a basic study was designed where students were asked an open-ended question. When you have a question about coursework, who do you ask and why? So they answered this question and they completed a measure of social anxiety. The goal of this was to gain a deeper understanding of socially anxious students' communication preferences. So thematic analyses were conducted with 3 separate coders and continued until saturation of responses was obtained. So this was with approximately 25% of the sample. And based on this and the overarching themes that emerged, a coding manual was created, and that was used to code the remaining responses. So we ended up with 4 overarching themes, along with a variety of sub-themes. So there was the theme of peers, which accounted for approximately 37% of the responses, and the most prevalent sub-theme was a fear of negative evaluation and discomfort. And this was essentially towards the instructors. So this drove students to ask peers questions because they felt threatened or intimidated, or they were worried of a negative evaluation on the part of the instructor. And next, there was a theme of instructors. So about 28% of the responses indicated that students would go directly to the instructor. And the main sub-theme here that emerged was knowledge and clarity. So students believed that the instructor would be able to answer their question the most effectively. There was also the main theme of peers and instructors. So 27% of students indicated that they would go to either, and this really depended on the context. So who they felt more comfortable with, depending on the question, or who they could get the information from best. And lastly, there was a theme of no one. So approximately 7% of the sample indicated that they would not ask anyone a question, and about 5% indicated this was because of feelings of anxiety. So these students would prefer either looking an answer online or just leaving the question unanswered because of these feelings. So shifting gears a little to focus on social anxiety, the overarching themes were coded quantitatively to examine the mean differences in social anxiety scores. And so we looked at the mean differences between these main themes. So we can see that social anxiety scores are the highest in the theme of no one, followed by peers, and these are significantly higher than in the theme of instructors and in the theme of instructors and peers. So the results of this study highlight communication barriers that are often present for students who experience social anxiety. And as we can see by reading some of the words from these student quotes, there are cognitive barriers present. So errors in thinking that prevent these students from openly communicating with others. A lot of the responses from socially anxious students echoed those central fears that I discussed at the beginning of this presentation, in particular, sounding unintelligent. And so that's bolded kind of in red. We see the word stupid quite a few times in their quotes. Because communication is such a central part of higher education, it's important for us to find ways in which we can promote learning and increase comfort among individuals who experience heightened social anxiety. So therefore, I developed a series of recommendations and pedagogical strategies for educators to implement in their teaching, specifically aimed to support students with social anxiety. For example, opening up anonymous channels of communication can benefit students with social anxiety, as they don't have to worry about negative evaluations or fear judgment. So for example, anonymous discussion boards or Mentimeters can be really powerful tools for these students. And of course, not everything can be anonymous. It's also important to encourage interactions. However, we can go about this in a very thoughtful way while considering students' needs and thinking about how we can support them as they step outside of their comfort zone. So for example, providing students with time before a group discussion, it can allow students with social anxiety to jot down notes and increase their confidence in the subject matter, as well as time to mentally prepare for social encounters or to even implement coping mechanisms such as breathing techniques or positive affirmations. This might seem really small, but to individuals who experience social anxiety, this can make a big difference in their social interactions. So given the time, I'm not going to go into all of these different strategies, but they were created with the intention of developing a professional development opportunity for instructors to increase their knowledge and awareness about social anxiety and to equip them with teaching strategies to support the learning and well-being of students who experience social anxiety. In the spring term, I developed an asynchronous module for TAs. And so this was offered for the first time in October as part of the University Fundamentals of University Teaching program through the CTE. So there were 19 students who completed the first offering, with quite a few signed up for the November session. In terms of feedback, we've had really positive responses with 100% of feedback survey respondents indicating that they agree or strongly agree that the session met their needs, that they learned something of relevance, and that they intend to apply ideas from this session. And so this last piece is really the most valuable outcome data for us. We want to ensure educators are coming out of this session with concrete strategies that they can start implementing right away to make that positive impact on socially anxious students' experiences. So in terms of future directions, the session that we are offering for TAs, we plan to adapt it for instructors, and then we plan to examine the efficacy of the professional development opportunity by following up with instructors as well as self-identified socially anxious students in classes where strategies have been implemented to further understand the impact that these pedagogical strategies are having on their educational experiences. Okay, thank you for listening. I look forward to any questions that you may have.
Excellent. Thank you, Kristen. I have been monitoring the chat function for some questions. So the first question has been posted for Christine and Ryan. And the question asked, is there a plan to follow up with students enrolled in the course over the rest of their undergraduate degree?
That's an idea. Ryan and I haven't really finalized our plan for the next study that we're going to do, but that's something that we can definitely discuss. We hadn't considered that yet, but it is something that we have individually thought about, and we might explore that.
Yeah, building on that, unfortunately, looking at the data that we already have, I think attrition would be a serious issue, even with this sort of 5-minute study during the term that they were actually doing the course. There's quite a bit of drop off, so that might be an issue if we try to track them without some sort of incentive.
And the other thing to note is that half the class were in their final year of study, so they're no longer at the university.
Right, and I guess I have a follow-up question to that. And I think, Ryan, you spoke to it a little bit already, is the attrition problem. Was there any discussion at the beginning to incentivize participation or have systematic follow-ups to ensure that those who completed time 1 would also complete time 2?
We did discuss that. Ryan, do you want to take this?
Yeah, we did talk about it because the model, at least in my department, is usually they get like extra credits for participating, but I think it might give sort of the notion of sort of almost coercion if they're getting that and we're really influencing them to participate. So maybe in the future we could think about some way to do it that is maybe less attractive.
Yeah, I was really concerned about optics, and this was first and foremost a course for students for their mental health and for them to help others with their mental health. And I did not want it to come across as an opportunity for us to use them as study subjects. So, and plus the other thing is that Ryan and I didn't have any funding for this project. But yeah.
Great. Excellent. The questions are coming in. Thank you, Ryan, for already providing the list of the scales you used. Another question came in. Would the AHS mental health literacy course ever be made a compulsory course for first-year students from all faculties?
So a lot of students recommended that this course be made compulsory for all students on campus. That came through as a real strong theme in the course evaluations aside from the study. And my gut feeling is that as soon as you make something mandatory, then you change the essence of it. And so I'm not personally in favor of making it mandatory. Also, we don't know what students what strengths they might be coming in with, and or what triggers they might be coming in with. So my preference is not to force anybody to take it, but to make it available and to make sure that students know about it and to encourage them to take it. And I think that that would, I believe that would be a good way to proceed, but it's not really up to me. So that's a good question for the Dean of AHS.
And a follow-up question to that. Would the course be made into a PD course for co-op students? I assume PD for professional development.
Yeah, I mean, we would be open to looking at that. I know there are a number of PD courses that co-op students do take, and some of the topics that they cover may overlap with some of the topics in this course, but certainly that's something that I would be open to. I have had conversations about making this professional development course as a mental health literacy certificate, or at least part of a mental health literacy certificate that could be offered through our lifelong learning center on campus. So those conversations are happening.
Great, thank you. Switching gears, I actually have a question for Kristen. If I could, please everyone continue to send in your questions into the chat. But Kristen, I was looking at the abstract during your talk as well, and quite a significant finding in terms of your ANOVA. I'm wondering, did you adjust for age and sex effects, knowing that there are gender and age effects with regards to social anxiety among younger populations?
So I didn't actually take that into account when I was running the ANOVA. My sample, because I was using university students and I was collecting data in the department, there was about 70% females and 30% males, but I did randomly select a population of females and I ran it with equal sample size of females and males, and I found the same effect. And with different analyses that I ran when looking at this data, the negative impact of social anxiety within that question. So looking at the responses of males compared to females in terms of asking either no one or asking peers, it was a lot more negative with the males in terms of the words being used. There's a lot more, I'm going to say like red words, a lot more in terms of feeling really intimidated, feeling quote unquote stupid compared to the responses from females. And there was also more males who would turn to no one instead of going to peers or instructors.
Interesting. So there are some gender effects there, which I think could be uncovered a little bit more with perhaps some qualitative work. Is that potentially a next step?
I think so. I think the first thing I really want to do is to ensure that the professional development opportunity is effective, and there's nothing that needs to be done in terms of future iterations. So any changes, I want to make sure it's actually having a profound impact on students' learning experiences. But I think from a different perspective, there's a lot more to uncover in terms of how both males and females experience education, males and females with social anxiety, because there are gender effects. Females are more likely to be socially anxious compared to males, but the severity of social anxiety among males is a lot higher. So there's a lot to further explore.
Absolutely. Thank you very much for that. We have a few minutes left, and if you don't mind, I'd like to take advantage of this opportunity and ask Ryan a very quick question in the last minute that we have regarding the multiple imputation.
Yeah, for sure.
And it's basically the justification for being able to impute so much missing data. And I do apologize for putting you on the spot, given that we only have about 45 seconds, but why not?
All right, the short answer is yes. I agree that there's a lot of reasons why this might not be sort of the best way to do it, because again, some were missing entirely the entire time too. Some were missing the entire timeline. So we're definitely going to have to go back and forth to decide which cases are really the best to impute from. But I think as long as we come up with a principled reason for that one cutoff, I think as long as we just keep simulating the other ones, I think we've done it like 35 data sets. I think it's honestly a good way to supplement our analyses so far.
Absolutely, thank you. And we are exactly right on time. So thank you very much to our three presenters, and I'll hand it off to you, John. Thank you.
Great, thank you, Mark, and thank you for everybody for an excellent afternoon session. Again, I'd very much like to thank all the moderators, the judges, the presenters, and poster session presenters for what's really been an excellent day. Thank you, all of you, for your participation. I would like to give some special thanks, though, to Grace Wong, Jerica Little, and Andrew Fowler Saunders, who are part of the Committee on Student Mental Health support team, who've done a huge amount of work to be able to make this event happen in a very short period of time, as well to Megan Lai and Derek Madge, who've been supporting us throughout the day around the management of the virtual conference setup, and it's really gone very nicely. Thank you, all of you, for your efforts. I'd like to now introduce Tejal Patel. Dr. Patel is a faculty member from pharmacy representing the Faculty of Science on the Committee for Student Mental Health, and Tejal will present the award for our poster prize winners. So Tejal, if you're there, take it away.
Thank you, John, for the introduction. So first and foremost, I would like to thank all those who presented their posters at our inaugural virtual conference in student mental health research. I must also congratulate the presenters on the breadth and the depth of research, ranging from relational body image and self-compassion and building mental health resiliency, all the way to the use of restraints in hospitalized individuals, cannabis use, and harm reduction for those who do not use drugs. So it's truly inspiring to listen to many students addressing student mental health in their 3-minute videos, and very difficult to choose one winner, as I'm sure my fellow judges, Megan Crouch, Andrew Belthouse, and Michael Wood would attest to. However, it does give me great pleasure to announce the winner for this year's virtual conference on student mental health. And that winner for the poster competition is Anita Kiefer and her colleagues on the presentation titled Comparing a Peer-Led versus Provider-Led Outreach Program for University Students. In the presentation, Anita Kiefer presented the findings of a study comparing the acceptability and satisfaction of peer-led to mental health provider-led outreach program for university studies, and found no significant differences between the two, and therefore informing the planning and delivery of such programs in the future. So please join me in congratulating Anita and her colleagues for this presentation. I'm not sure if she's here, but if she is, I'd encourage her to connect with the committee to be in touch with about the price. Thank you.
That's great. Thank you, Tejal, and congratulations, Anita. I was able to sit in on your poster session as well, and you guys did do a great job. So congratulations for that. That's really wonderful. The next person I'd like to introduce is Karen Parkinson, who's one of the co-chairs of the Thrive Week. So Karen, if you could give some remarks on behalf of yourself and Calpita, that'd be great.
Absolutely. Can you hear me okay?
Yep.
Okay, thank you. So we just wanted to pop in, Calpita got pulled away to another engagement, so it's me by myself. Her and I are co-chairs of the Thrive Core Committee, and so we just wanted to welcome you to Thrive Week 2020, which is this week. Thrive is a series of events focused on building a culture of well-being and normalizing mental health struggles. It's also a mindset that encourages one to flourish. For those of you who've never heard of Thrive, we have 3 goals in mind. Number 1 is to increase mental health literacy. 2 is to build healthy habits and self-care skills. And 3 is to foster a supportive and inclusive community. And as we know, the university has adopted the Okanagan Charter as a collaborative framework to promote the health and wellness of our students and the broader campus community. So our commitments include a specific emphasis on mental health as part of a broader spectrum of health and wellness for everyone within our community. So Thrive does align with the call to action 1 in the Okanagan Charter by helping to create a supportive campus environment and generate thriving communities, and by supporting personal development for our campus community. So I just wanted to welcome you, encourage you to get involved with Thrive 2020 and any future Thrive days. You can attend our virtual events, you can host your own event, or even become a Thrive ambassador. So thank you everyone for the time, and have a good week.
Thank you very much, Karen. It's always been great to participate in the Thrive events, and let's hope the next Thrive event we'll all be able to participate together back in a normal physical environment. Thank you for all your efforts on behalf of the university in that regard.
Thank you.
And finally, I'd like to introduce our provost, Jim Rush, who has been involved in student mental health efforts at least back to the time when he was Dean of Applied Health Sciences, where he played a very active role on the President's Advisory Committee on Student Mental Health and helped to formulate the set of recommendations that went forward. And I can say as Vice President Academic and Provost, he's been incredibly supportive of the Committee of Student Mental Health and mental health initiatives that have gone on across campus. So we're grateful, Jim, that you're able to find the time to join us to make closing remarks. Over to you, Jim.
Yep, thanks very much, John. It's my pleasure to be here. Thank you for having me, and I hope you've had a great and productive day. I know it's been a really important day of discussions and dialogue on an issue that's, as you indicated, very important to me and, of course, to the university in general. As you indicated, I did serve on the PAC SMH as Dean of AHS. It was my pleasure to do that, and it's been my pleasure to follow that through the implementation phase under COSM's leadership and your leadership, John, with many enthusiastic participants from all over the university and outside the university. And it's been great for me over the years to see the student mental health forums that have been hosted by COSM colleagues, and it's been exciting to see the engagement that's created for students and staff and faculty to hear what's going on campus and to interact with the work that's going on in an iterative way, which I think has informed the way that the work's evolved and continued. As you indicated, and as this group attests to, the mental health and wellness of our students is a key priority to the university and to my office. And so I thank you for your work and leadership and creating these engagement opportunities to all the folks that are involved. As you're no doubt aware, and as I'm sure that was peppered many of your discussions today, much has changed in the world and on the university from the time that this initiative has been undertaken and since we began this important work. And of course, this last year has not been a typical one for the university or for the world as we navigate the pandemic and the disruption to our working and studying routines. And that's no doubt had a huge impact on mental health and stresses for students and for staff and faculty. We certainly live in an age of heightened stress and uncertainty, and that's just permeating everything that we're doing in our work lives and our home lives, and it's an additional challenge. Throughout the transitions and the disruptions that have come our way, though, I'd say that the university hasn't lost sight of the fact that supporting our students and their well-being is remaining a top priority throughout that, and that adjusting to the disruptions and to the longer-term changes that follow the disruptions are our challenge. Hopefully, we're responding well, and through strategic mechanisms that groups like COSM are creating, hopefully we're laying the groundwork that those long-term changes will be a natural following to dealing with acute disruptions. So as much as we can address financial strain, challenges that come up, or as much as we can add additional counselors to add to needed increases in health services and promote services in virtual ways to meet our acute needs of the way that we're delivering academics, and still being able to engage on well-being issues during times of isolation and remote studying. It really that's responding in my mind to an acute but evolving situation that is another way of me getting around to saying it makes it even more so important in our present circumstances, vividly underscore the importance of the research aspect for dealing with student mental health and the evolving nature of the challenges to student mental health that will accompany the transformation of the way universities operate and society evolves, for informing university policies, procedures, and generally speaking, the need for research. I know, although I wasn't able to join the entire time today, that you've covered the gambit of COVID related stresses, of data use and accessibility in general, of substance use, suicide prevention, racial injustice, intervention, and health promotion related issues, which I'm sure you had to narrow it down to that selection of topics to have a one-day forum. It's also important, and of course, research into how to meet evolving needs is most important. I wanted to just share an observation just to thank the COSM committee on another note about the considerable progress you've made on implementing the recommendations that did come forward from the PAC SMH in such a thoughtful way over time. I'm sure you've already talked about this earlier in the conference, but of the 36 recommendations, I know that about 2/3 of them have been completed and others are substantially underway and near completion, with a few outstanding ones that are being tackled between now and April for completion. Just want to thank you for the resilience and longevity, the ongoing commitment that this committee has made to undertaking that activity on behalf of the university. So thank you. Last June, I know that we launched the Wellness Collaborative to bring together partners from across campus to promote existing wellness initiatives, to identify needs as well, and to set shared wellness priorities for all members of the campus so that we can start to integrate what has come forward as recommendations and priority into everyday operations in life, and give a future framework on which to build our progressing work for students and employees in this important area. And I know we're all committed to keeping the momentum going on this work. I certainly take the opportunity to say I certainly am. Discussions are underway, as you know, to determine ongoing mechanisms to support the commitment to student mental health, informed by your very good work, as I mentioned, and many people on our campus have highlighted today during this forum. I'm so glad that this was able to occur virtually today. It's been very, by its very nature, it's highlighted how the work of this critical issue of student mental health continues even under challenging conditions. So congratulations for being able to organize under those conditions and do this meaningful event today. As you can see and tell, and I know you're all shared enthusiasts on this area, this isn't the end of the conversation. We're going to keep the conversation going on the campus both today and into the future. And I'd like to just conclude as Jim thanking the researchers and poster presenters today for their enthusiastic participation in the conference activities of the day, and to our students, faculty, and staff who've taken the time to attend today and take part in the important discussion on student mental health. Thank you for being connected with us today. Let me just also once again say thank you to COSM, to the organizing committee of leaders for this event today, and to thank you all for attending the Student Mental Health Research Conference. And I hope you enjoy the rest of the day. And again, this has been it's been a highlight for me, even though I wasn't able to join the whole conference today, to know that this is happening. So thank you.
Great, thank you very much, Jim. Very much appreciate those words of support, and thank you to everybody who played a role in today's event. I think by all counts, this has been a great success, and I look forward to us having a repeat of this conference in future years, hopefully in person, where we will have a bit more chance to interact directly with each other. So thank you again to the organizing committee as well for today, and for everybody, enjoy the rest of your day. Take good care of yourselves, be well, and hope to see you soon again. Thank you very much.